Welcome everyone to the Spine Conference. This month's lecture will be on posterior cervical foramenotomy. The patient, this is not the patient himself, but a man very similar to him. The patient is a 75-year-old man with a chief complaint of right upper extremity pain that radiates down into his thumb. Specifically, the symptoms are in the lateral arm, lateral elbow, outside the elbow, into his radial forearm, the portion of the forearm that's around the radial bone, and then into his thumb. He has no symptoms on the left. The dates are important in this patient because he's had surgery previously, so with the dates you get an idea of how long the process has been going on. He presented in November of 2014, and he had symptoms for about 2.5 years, so a long time. He was really miserable with these symptoms. He had previous C4 to C7 ACDF, which stands for anterior cervical discectomy and fusion, for the same exact problem, July 30th, 2013. This surgery went very well, had no problems, but very unfortunately he had absolutely no relief of his symptoms in his arm. The pain never went away. He then was sent by the surgeon to the surgeon's partner for injections in the spine. This did not help. He sought another second opinion for more injections. The injections did not help. He had physical therapy, pain medicine, just constant pain. He then found me through the internet as a second opinion. Past medical history only significant for total knee arthroplasty and a history of myocardial infarction in 2010, but relatively healthy. He's right-hand dominant, retired construction worker, and his body was very robust. He was a very strong man. Height and weight 5 feet 11 inches, 248 pounds. He had, on a physical examination, pain worse with range of motion of his neck, and mild limitation of his neck, 45 degrees of rotation. Otherwise, no motor sensory deficits. This is just a dermatomal map of the cervical spine, and so nerve roots that come from the spine, they can cause pain and numbness along a distribution, and these distributions are either called, if it's sensory, a dermatome, or if it's pain, it's also called a dynatome, I think, a painful area. And for this man specifically, his pain went down into his thumb, so classically it should be C6, but there's always a chance it could be C7, as the nerves do have some crossover sometimes. But usually it's thumb is C6, and you can see here the other dermatomal distributions as C7, C8, T1. Now this is a diagram of pain that emanates from the facet, and this is a different type of pain in a different dermatomal distribution. That diagram came from the study from 1990 of Bogduk, where he injected with a needle and saline. He injected into the facet joints of the spine, and then documented where these research participants felt pain. So it's kind of a scary procedure, you know, someone sticking a needle into your spine, into your facet joints, but it was very important because it gave us the information of where do these things hurt, where do these facet joints hurt. On the left is another example of the dermatomal distribution. Now, a way to remember this is from a German textbook. If you can recall the human in this position, say touching his toes with palms in, the dermatomes go up and down, and this is the fetal position, and this is probably why it looks like this, that we developed in utero. So C2 by the ear, C3, C4, C5, C6 again goes to the thumb, a little bit of index, C7, middle finger usually, C8, small finger, fifth finger, T1, T3, and you can see the lumbar dermatomes as well. Just as a review of the motor sensory exams, C5 nerve root gives deltoid strength. It also gives partial elbow flexion strength. The reflex is the biceps tendon, and the sensation is the lateral border of the arm. C6 gives wrist extension. The reflex is the brachioradialis tendon, and the C6 dermatomal distribution, as we discussed, is radial forearm and thumb, which is this patient's. C7 is wrist flexion. C7 it gives tricep strength. Also, the reflex is the triceps tendon. C7 is usually middle finger. C8 is a finger flexion. There's no reflex, and the sensation is the fifth finger, fourth finger. C8 is commonly confused with the ulnar nerve. C8 nerve root emanates from the C7-T1 disc space. This is just a cartoon example of pushing down on someone's head. This test is called the Lermit's test. Pushing down on the head also pushes down on the frame, and it can give you pain running down your arm. I think if one is seeing a patient and that person is unclear of the neurological level, neurological deficits, they're not sure of the exam and how to correlate it and describe it to another physician, the best thing and the easiest thing you do is go to Google and search for the Asia spinal cord injury sheet. So Asia stands for American Spinal Injury Association, and they can give you this very simple sheet that you can fill out and read carefully so that you can document the neurological exam, where the patient is at that time, and also you can communicate with another physician. So if one's not sure of what the neurological deficit or problem is or abnormality, I think it'd be best to just look this up. So on X-ray, this is an AP view of the cervical spine or front view. He's had a C4 to C6 intercervical discectomy infusion, and inserted into those levels were these standalone devices. It's basically a piece of metal with a piece of plastic, usually PEEK, with screws, and there's no plate as the implant with the screws. The screws go through the implant and give the patient stability. You can see here it's also in the AP view, these very large bone spurs or uncle osteophytes at C4, C5, C5, C6. This is a lateral or side view. Again, the same implants, and this little radiographic marker tells you how back posterior the implant is. So you know this is the posterior portion of the vertebral body, and behind this or posterior to this is where the spinal cord is. So when you insert these in the operating room, these little markers are helpful to know where it is, so that you know that the implants are not going into the spinal canal, which could be catastrophic. Also note on the lateral view and the side view, so the C3, C4 disc is slightly decreased, and the C6, C7 disc is slightly decreased, and there are osteophytes there. Otherwise, the implants look okay. This is an oblique view, looking at the foramina. When I talk to patients, I tell them that the foramina is the hole where the nerve runs through, and the foramina look okay on the X-ray. This is just a photograph of just one type of standalone device. I don't think this is the type of device that the patient has, but it's very similar to this, where you have a piece of metal, a piece of polyethylene or plastic, and then the screws go through the implant and the vertebral body, giving the spine immediate stability after inserting the implant without the use of a plate. This is what it looks like in the spine. The other way to do the anterior cervical discectomy is inserting a bone graft between the disc spaces, and then a plate and screws on top, which is what I usually do. And there's a couple of reasons I prefer this than the standalone device. The first is the post-op CAT scan after a year or two. So this is a sagittal cut of a CAT scan in a patient who's had a previous C3 to C5 fusion, and in here you can see the allograft that was inserted. It's very, very clear that this patient's fused. So when you use allograft, it's helpful in the post-op period because it's very simple to know where the patient has fused. Also, I think there's a larger fusion area to the graft. So in this concept, only the middle part of the implant is where the fusion takes place, while in allograft, the entire area fuses. So I think using allograft increases the fusion area. So here's an MRI of our patient, and the implant throws off a lot of artifact. And you can see here's the spinal cord and the spinal canal, the vertebral bodies. And the MRI was not so helpful because I really couldn't see if there was any pressure on the spinal cord, and I was concerned about this one area, whether there was something in the spinal canal during the procedure compressing the spinal cord. I knew it was not the implant because of the radiographic marker, but I couldn't be sure that maybe some disc material or a bone spur was compressing the spinal cord. This is an MRI at C4, C5. Again, you see the artifact. So I wasn't sure that there was nothing within the spinal canal. C6, C7 axial cut also showed some foraminal stenosis here. The foramen again is the hole where the nerve runs out. The spinal cord's here, and the nerve runs out here. So he did have some foraminal stenosis at C6, C7. Again, another view, and at C4, C5 there was artifact here, which mimicked some pressure on the spinal cord, but most likely it was artifact. So this is just a sagittal view, cross-sectional anatomy, so you understand the spinal canal is here, the spinal cord is within the spinal canal, and out here is the foramen with nerve root exits. And in this cartoon, this patient has foraminal stenosis. So the foramen is compressed here by overgrowth of the uncus, UNCUS, or the joint of Luschka, LUCHKA, which compresses the nerve root. The other place that you can have compression is here from the facet. The facet also can compress in towards the nerve root as well. This is a sagittal cross-sectional anatomy. So this level is normal. Here's the nerve root. Posterior to it is the facet. Anterior is the uncus, where the two vertebral bodies come together at the level of the foramen, and the nerve root. So this is a disease level, and due to the arthritic disc, most likely, the uncus and the superior articulating facet overgrow, and there's a bone spur, and the bone spurs can compress the nerve. So this pressure on the nerve can come from posterior, the backside, from the superior articulating process, or anteriorly from the uncus compressing the nerve root. So here's our patient at C2, C3. This is an axial cut CT myelogram. I ordered the CT myelogram because I wanted to be sure that there was nothing compressing the spinal cord at C4, C5. Remember the artifact on the MRI. So here's the spinal cord. This foramen's free. This foramen's free. C2, C3 looks fine. C3, C4. The right foramen did look stenotic as compared to the left, but he had absolutely no right-sided C4 symptoms, so I felt it was asymptomatic. Here's C4, C5, the level in question. You can see here the marker, so the implant's in a good position. And here's the spinal cord. So after this myelogram, I was sure that centrally the patient's spinal canal was fine, but he did have some level of foraminal stenosis. It did not look terribly worse, right versus left. This is just an axial cut of the CT myelogram through the C5 pedicle, and here's the pedicle from here to here, and here's the foramen for the vertebral artery. C5, C6, some mild foraminal stenosis bilaterally, but nothing terrible. This is a coronal cut through the CAT scan CT myelogram, and you see this artifact from the Sandlin device and a black line. So this is what's unfortunate about these implants, is that they throw off artifact on all the studies, especially the MRI, not so much for the CAT scan, but also the CAT scan. So you're not sure of if the patient's fused or not. And you can see here again a black line, but it could be artifact. And you can see here the uncal osteophytes at C4, C5, C5, C6. This is another coronal cut, and again there's artifact across the disc space from the implant, so I'm not sure if he's fused or not. So there's a good chance that this patient also has a non-union on top of some level of stenosis in his cervical spine. That's probably left over from his first surgery. There's a very good chance he may have a non-union as well. And this is a good view of the foramen here on the right, and you can see here that the uncus is digging into his nerve root. This is a sagittal cut. You can see here all the facets and lateral masses, and you can see here this foramen is a bit tight. Not a good view though. Again, sagittal cut. It's not clear whether he's fused or not. C4 to C6. Another view. Just another view of the anatomy, spinal cord, the foramen, and inside of the foramen, the dorsal root ganglion is present. So when this is stenotic, the dorsal root ganglion holds all the pain receptors in the nerve root. It can be very painful. This is a coronal anatomical drawing of the uncus. So the uncus is made up of the inferior portion, which is sort of like a goalpost, and the superior portion which sits inside of it. And it's usually this inferior portion that overgrows. And you can see just deep to the uncus is the facet capsule. So when this facet capsule becomes hypertrophic, that can compress the nerve root in the foramen, and also, of course, if there's an osteophyte, it can compress it. I just wanted to show this just to remind everyone that the nerve root courses inferiorly. It goes from top to bottom at an angle as it exits the foramen. One more view of the anatomy, which shows the uncus here anteriorly, posterior the superior articulating process, which compresses the foramen. This is a axial cut through an anatomical specimen, and the only reason I showed this is it shows you how much musculature you have posteriorly. The posterior portion of the neck has these very stout muscles, and the reason for these muscles are that we need them to keep our neck upright. Basically, we need to extend the neck to keep our head in an upright position. So posterior approaches in general cause more pain than anterior approaches because all these muscles have to be transgressed during the operation. So we've talked a lot so far, but we still haven't gone over what the subject matter is, and that's foramenotomy. So foramenotomy is basically opening the hole where the nerve exits. It's also called a keyhole surgery because the surgery is done through a very small hole. So this is a drawing of what a foramenotomy should look like. The medial half of the facet is basically removed of the lateral mass, and it's created like in a circular shape. And here's the nerve root. There are always some vessels here at the junction of the dura and the nerve root. And this is the sawbone after the foramenotomy, what it should look like. Again, just to review the anatomy, here's the lamina, here's the lateral mass, and you find the medial border of the lateral mass, the lateral border of the lateral mass, and the V where the two lamina come together. And then you make a circle opening up the foramen, and you go about halfway to ensure that the pedicle is open. And this was just a sawbone. I just wanted to show that here's the foramen looking in through the spinal canal, and you can see this superior articulating process of the facet is usually the offending member. This has to be removed to open the foramen. This is a CAT scan which shows the uncus and then posterior the facet, and if you do a foramenotomy, you remove this basically to open up the foramen. Same view with the MRI scan. You see this superior articulating facet has to be removed to open up this foramen. Here's another drawing of what it looks like after foramenotomy when you see the nerve root. So I wanted to show everyone a video of doing a foramenotomy on a sawbone, because it's a lot easier to see on the sawbones, and during the surgery it's very bloody. It's hard to get a good view to understand things, and also with the sawbone you can turn things around. So where the nerve root should be, I inserted a blue vessel loop, and so I check the side, outside, medial, and now I'm making my circle. Where the vertebral artery is present, I put a white vessel loop. So when you do these things, you create something through your mind's eye. So I know I want to make a circle on the medial border of the facet. So I did medial and lateral portion of the lateral mass, and now I'm creating my circle. You have to remove some of the lamina to know where the spinal canal is and the dura as a reference point. So the inferior facet here can be removed very quickly because there's nothing next to it. It's just the only thing that's next to it is usually the bone of the superior articulating process. So this is removed quickly to expose the superior articulating process, which is the offending anatomical structure. And you can see the blue vessel loop is where the nerve root is, and it's coursing like it usually is. So again, checking your landmarks. I think it's best to make a small triangle. You see how I'm making a small triangle there in the lateral portion because that's thicker. And then at some point you see a translucency within this facet, and you'll even see it here in the see that little translucency right here. You know you're very close. At that point, you may want to use curettes or a kerosene punch. I just did it quickly with the bird just for timing, and that should and remove that little bit next to the nerve root should fully decompress the same nerve root. You can see that superior articulating process right up against where the nerve root should be. So this is where the uncus is, and you can see by removing that you open up where the uncus is. Now I'm rotating it again so you understand the blue is the nerve and the white is the vertebral artery. The vertebral artery is deep to the nerve root, so there's very low probability you could hit the vertebral artery with this approach because you always stop by the nerve root. You see the nerve root first, so then you stop your drilling. You see how the nerve root is anterior to the vertebral artery. Now with the bolted probe, I'm feeling the pedicle wall. That's the lateral portion of the pedicle wall, and then going in front just to show you that's the superior portion. That's the most superior portion of the pedicle, and that's the uncus. And here's the medial portion of the pedicle, lateral portion of the pedicle, medial and lateral, and you have to palpate those things to make sure you're free, and that's the lateral pedicle. Again, superior portion of the pedicle, that's where it's present, so you get an idea of the anatomical references. And then on the top, you feel the top pedicle, superior and lateral. So if you can feel both superior and lateral portions of the pedicle, you know your foramen is wide open. Again, top of the pedicle is right there. Lateral portion of the pedicle. And this just gives you an idea how the nerve traverses through the foramen. This just shows you the superior portion of the pedicle. So now what to do in this patient. Just I like to review things. He's 75, he has right arm pain. He's had previous C4 C6 anterior cervical discectomy infusion. The implant position is good. I think he may have a non-union present. Not sure, so that has to be explored. He needs his nerve roots decompressed. He also may have C6, C7 stenosis of the foramen. The disc is decreased on the lateral view. I do not think the C3, C4 segment is symptomatic. So the question is what to do. You could do an anterior approach. Just do the same exact operation, basically the C4, C7, ACDF, but that would require removing this implant, which may be very difficult, may be impossible, and also it may require so much removal of bone that you'd have to basically remove the entire vertebral body or perform a corpectomy. The other option is a posterior approach. In a posterior approach, centrally he doesn't have to be decompressed, but just the foramen needs to be decompressed. So it would be a foramenotomy, C4, C5, C5, C6, C6, C7, and then I think it would be a benefit from a fusion to avoid persistent motion afterwards and to ensure that a fusion takes place. So basically, this was the operative plan of foramenotomies, and then fusion, and then just instrumenting the one side because I was going to create very generous foramenotomies because I wanted to be sure he was open, his nerve was open, and then this is where I was planning on putting the screws in the rods. So the surgery went extremely well, and this is a postoperative cascade coronal section, and you can see here the very generous foramenotomies on the right, C4, C5, C5, C6, and also at C6, C7. This is another coronal view which shows you the foramenotomies. This is the side of the instrumentation. And you can see here on this side was totally asymptomatic. You can see here this superior articulating process that was compressing the nerve root somewhat. This is on the side of the foramenotomies, and you can see there's very wide foramina after the decompression. This is just a axial cut to show the trajectory of the lateral mass screw at C4, and this is where the vertebral artery would be. And you can see here the foramenotomy is very generous, half of the facet has been removed, and you can see this is where the nerve root lives, and here's where the vertebral artery lives. This is just air because it's a post-operative CAT scan. This is just a diagram which shows you the trajectory of the lateral mass should be 25-30 degrees, and that's to avoid hitting the vertebral artery. Here's at C5, C6 again. The foramen's wide open. This is on the other side. There's bone graft. I fused the opposite side. And this is C6, C7, a wide foramenotomy. This side looks stenotic, but again, it's not symptomatic. So post-op, patient had absolute resolution of his pain after 2.5 years. So he was extraordinarily happy. This is the second time that I went over this conference. My actual conference, which I did earlier this morning, I somehow wasn't able to record it, so I just re-recorded this conference by myself. Thanks everyone for coming. This is yours truly and my brother celebrating New Year's Eve. See you next month.